Carotid sinus hypersensitivity. Amal Shine, MD Brock Cabot, MD Hugh R. Peterson, MD, FACP. Basics. Description. The carotid sinus, located at the bifurcation of the internal and external carotid arteries, contains baroreceptors that are responsive to increases or decreases in arterial pressure. It plays a central role in blood pressure, BP, homeostasis. An endogenous increase in BP or external pressure applied to a carotid sinus causes an increase in the baroreceptor firing rate and activates vagal efferents and/or inhibits the sympathetic discharge to the heart and blood vessels, resulting in a slowing of the heart rate and/or drop in BP. In carotid sinus hypersensitivity, CSH, stimulation of one or both carotid sinuses causes an exaggerated baroreceptor response that can result in dizziness or syncope. CSH is defined as asystole for at least 3 seconds and/or a drop in systolic BP of at least 50 mm Hg during carotid sinus massage, CSM. CSH is generally divided into 3 subtypes, based on response to CSM: cardio-inhibitory, 70–75% asystole for at least 3 seconds; vasodepressor, 5–10% fall in systolic BP of at least 50 mm Hg; mixed, 20–25% combination of the first 2 subtypes. Carotid sinus syndrome, CSS, typically, but not consistently, refers to CSH with syncope and may be classified as spontaneous CSS, syncope after accidental mechanical manipulation, trigger, of the carotid sinuses, e.g., shaving, tight collars, or tumors, induced CSS, syncope diagnosed by CSM. Although no mechanical trigger is found. Epidemiology: disease of elderly, virtually unknown in people aged 50 years, more prevalent in males by ratio of 4:1. Typical patient is an older man, usually with a history of coronary artery disease, CAD, and hypertension, HTN, with right CSH left CSH. Prevalence in 2006: CSH was found in 39% of unselected adults greater than 65 years of age using standard diagnostic criteria, 1, and found to be comparable with 2019 review of prevalence data, 2. CSH may be a cause of the symptoms in 30% of elderly patients with unexplained syncope. Etiology and pathophysiology: the exact mechanism of CSH remains unknown. Changes in any part of the reflex arc or the target organs may give rise to this condition, or it may be a part of a generalized autonomic disorder associated with autonomic dysregulation. Associated with resting sympathetic overactivity and increased baroreflex sensitivity. Bradycardia and asystole seen in cardio-inhibitory and mixed CSH subtypes appear to be mediated by vagal efferents, whereas vasodilatation and arterial hypotension in the vasodepressor and mixed subtypes are attributed to decreased sympathetic tone. Symptomatic CSH has been shown to be associated with impaired cerebral autoregulation, and in asymptomatic CSH, it was found to be normal. Atherosclerosis may diminish carotid sinus compliance, resulting in a reduction in afferent impulse traffic in the baroreflex pathway. 3. CSH is often idiopathic but can be caused by carotid body tumors, inflammatory and malignant lymph nodes in the neck, extensive scarring from prior neck surgery in the area of the carotid sinus, metastatic cancer. Risk factors: male, gender, advanced age, CAD, HTN, DM. Commonly associated conditions: 6. Sinus syndrome, atrioventricular block, CAD, HTN, orthostatic hypotension, vasovagal syncope, Alzheimer's disease, Parkinson disease. Diagnosis: history, recurrent syncope, usually sudden, unexplained, of short duration, seemingly spontaneous, and with complete recovery, although fractures and other injuries may occur. Unexplained falls. Evidence of a causal relationship is suggested between falls and the cardio-inhibitory subgroup. Dizziness manifests as transient lightheadedness or pre-syncope but not usually as true vertigo, associated more with vasodepressor and mixed subtypes. Syncope may be associated with prodrome or retrograde amnesia. Causative or exacerbating factors: any CSM-like maneuver such as shaving, wearing tight collars, or turning one's head sharply. Neck tumors, extensive neck scarring secondary to radical dissection or radiation. Fibrosis, and neck trauma. Certain medications can potentiate symptoms associated with CSH, digoxin or beta blockers, especially with cardioinhibitory subtype, physostigmine, morphine, methacholine, increase vagal sensitivity and may predispose to cardioinhibitory subtype of CSH. Physical exam normal unless carotid baroreceptor is stimulated, then bradycardia, hypotension, pallor, diaphoresis. Differential diagnosis: neurocardiogenic syncope, postural hypotension, situational syncope, postural tachycardia syndrome, POTS, primary autonomic insufficiency, hypovolemia, dysrhythmias. 6. Sinus syndrome, cerebrovascular insufficiency. Other causes of syncope, e.g., metabolic, psychogenic. Electrocardiogram may demonstrate sinus pause, S, or atrial ventricular block. Carotid duplex scan to rule out carotid stenosis in presence of a brute. See the following section, Diagnostic tests and interpretation. Diagnostic procedures / other CSM is indicated in patients greater than 40 years of age with syncope of unknown etiology after a negative initial evaluation. 4b. Commonly accepted technique for accurate diagnosis involves the following steps. Patient in supine position for 5 minutes with continuous BP monitoring and ECG, on footplate type tilt table for increased diagnostic accuracy. Baseline BP and ECG are recorded. For 5 to 10 seconds, apply firm longitudinal massage over the right carotid sinus, between the superior border of the thyroid and the angle of the mandible, at the site of maximal pulsation. Note that light pressure over the carotid sinus will not reliably produce a hypersensitivity response. Record symptoms, BP, and note ECG changes. Discontinue if asystole greater than or equal to 3 seconds if initial test non-diagnostic. Apply pressure to the left carotid sinus while the patient remains supine. If still non-diagnostic, repeat in 70-degree head-up tilt, first on the right then, if necessary, the left, allowing time for hemodynamic adjustment to the head-up position. Evidence behind the testing strategy. Right side first. Up to 66% with CSH have positive response on the right. If a positive right response, no need to repeat test on the left side. 30% of CSM exams are found to be non-diagnostic in the supine position. Positive predictive value increases from 77% to 96% with a specificity of 93% by performing CSM in the 70-degree position. 5. Absolute contraindications for CSM testing. Carotid brute present, must examine via carotid ultrasound with Doppler first. No testing if 70% stenosis. Supine only testing if 50-70% stenosis. Myocardial infarction, transient ischemic attack, or stroke within the past 3 months. Relative contraindications to CSM testing. History of ventricular tachycardia or ventricular fibrillation. False positive results with CSM are relatively common in the elderly. Care should be taken to exclude other causes of syncope. Neurologic and cardiovascular complications have been reported during CSM. Cardiovascular complications, primarily arrhythmia, are extremely rare. Transient neurologic symptoms and signs occur in up to 0.9% of patients. Persistent neurologic deficits are extremely rare following CSM. Correctly performed CSM should be considered a safe, low-risk procedure. 3c. Test interpretation. Standard positive response criteria. Asystole greater than or equal to 3 seconds and / or drop in systolic BP greater than or equal to 50 mmHg, is based on historical observations, although expert review of more recent data suggests these criteria may be too sensitive. 6. C. Specificity of the CSM technique increases if reproduction of a patient's syncope is demonstrated during a test. 4b. Treatment. General measures. No treatment is required for asymptomatic individuals. High dietary salt intake and increased fluid intake may be helpful to maintain intravascular volume in patients with vasodepressor subtype and absence of other cardiovascular disease. Medication. First line. No single agent has demonstrated long-term effectiveness for treatment of recurrent and symptomatic CSH. Second line. Fludrocortisone or midodrine may be used to improve orthostatic symptoms in patients with vasodepressor subtype, not approved by FDA for this indication. However, fludrocortisone causes sodium and water retention and should be used with caution in elderly patients with heart disease. An adverse effect with midodrine is that it increases mean ambulatory BP. 3. C. Atropine may be used in the acute setting in patients with cardioinhibitory subtype with bradycardia. Some evidence of benefit from sertraline and fluoxetine in patients unresponsive to pacemakers. 3. See surgery/other procedures 2017 College of Cardiology/American Heart Association/Heart Rhythm Society, ACC/AHA/HRS, Guideline for the Evaluation and Management of Patients with Syncope. Recommendations. Class IIA indication. Permanent cardiac pacing is reasonable in patients with carotid sinus syndrome that is cardioinhibitory or mixed. Class IIB indication. It may be reasonable to implant a dual-chamber pacemaker in patients with carotid sinus syndrome who require permanent pacing. Permanent pacing may reduce the frequency of symptoms but may not completely eliminate them. Surgery for patients with CSH secondary to mass effect from tumor burden carotid sinus denervation by surgery or radiation therapy is no longer recommended because of the high rate of complications. Ongoing care patient education. Avoid precipitating maneuvers, as described above, that place pressure on the neck, such as tight collars and neck tees. With syncope, restrict driving or other potentially hazardous activities until the patient is cleared by the physician. 4. Avoid precipitating medications like vasodilators and those temporally related to symptoms. Teach patient to assume supine position if prodromal symptoms or pre-syncope occurs. Explain diagnosis, provide reassurance, and explain risk of recurrence. Prognosis. The presence of CSH has not been demonstrated to confer an independent mortality risk. Untreated CSS patients have a syncope recurrence rate as high as 62% within 4 years. Patients with cardioinhibitory CSH who received a pacemaker had a significant reduction in their mean number of falls, from 9.3 to 4.1 falls in a 1-year follow-up period. 3. References. 1.